Well, hello everyone. My name is Jonathan Litt. For those of you who don't know me, I'm a neonatologist here at Stanford and a perinatal epidemiology and health services researcher. I'm also a member of the education community at MCHRI, and it's actually my distinct pleasure to be moderating this session, which is so exciting, and it's, I think, one that we all really look forward to. We get to hear from our emerging leaders in the field, so early career researchers and trainees, people who are doing really exciting work at the very beginnings of their career. I will introduce each speaker as they come up. We'll have a bit briefer presentations and then time for a question or two after each presentation. The first speaker I would like to welcome up to the podium is Vanessa Kamari, who is going to be speaking to us about non-invasive profiling of small intestinal inflammation in celiac disease.
Hi, everyone. Thank you so much for the introduction. It's really wonderful to be here. I'm really excited today to share with you the work I have been doing in the past year. Under the mentorship of David Drellman and with the help of MCHRI postdoc fellowship, where I've been looking at new methods to measure non-invasively small intestinal mucosal inflammation in patients with celiac disease. So one of the biggest challenges in celiac disease is that we don't have enough tools to monitor what's happening inside of the gut. On one hand, the current gold standard, which is endoscopic biopsy, is invasive and not very practical for regular follow-up, and as you can all imagine, especially in kids. On the other hand, serologic tests don't always reflect accurately disease activity or mucosal inflammation. So this really creates a critical need for non-invasive methods that would measure inflammation directly at the small intestine, which is the site of pathology in celiac disease. And that's exactly the challenge I aim to tackle in the INFLAME pilot study. So to overcome these challenges, we partner with a biotech company called InVivo on a sampling device that is called CapScan. It's an ingestible capsule about the size of a vitamin pill that passively collects intestinal fluid as it travels through the gut and before it's recovered from the stool. So how does it actually work? First, the patient will swallow the capsule, and then the capsule outer coating will dissolve in the GI tract once it has encountered a specific pH and expose a tightly wrapped, long, thin tube. As the tube unfolds during transit, it will passively collect intraluminal fluid from the duodenum through the first part of the ascending colon. And this is what it looks like in real life. Obviously, this is cleaned externally. So this is after CapScan tube is recovered. What we usually do, then we will section this CapScan into different segments. It might not be very clear here, but this would be based on observational things like pH, like color, and then we'll measure the pH. And with the assumption that each of these segments represent different areas of the small intestine. And then we will collect aliquots from each of these segments from the CapScan, and then we can use those for downstream analysis. So with those samples that I have collected from the CapScan, now we can profile mucosal inflammation. So how exactly do we do this? We have collaborated with HIMC at Stanford to develop a customized Luminex multiplex immunoassay panel that can measure simultaneously around 115 inflammatory analytes. And those include anything like cytokine, chemokine, and other markers on the CapScan fluid. And then we wanted to demonstrate this in practice. So we conducted the pilot INFLAME study where we enrolled participants that are 14 and older into a 24-week longitudinal pilot with two groups. The first group is newly diagnosed patients with celiac disease who were still eating gluten and are planning on initiating a gluten-free diet. And then we also enroll healthy controls. And across 5 time points over the 24 weeks, participants will, at each study visit, they will swallow a capsule. Then at each visit, we will collect blood, saliva, stool, and then we'll have them fill a standardized diet questionnaire as well as symptom questionnaires. So this allows us to really observe between different disease states and then also within person changes as patients newly diagnosed with celiac disease are starting treatment. We have optimized our protocols to and are now able to detect reliably 94 analytes above the limit of detection with very good reproducible measurement. Next, we asked whether distinct inflammatory markers from CAP scan can tell us something different than if we have measured them from the plasma. So what we did is that we used pair samples from the same visit where we measured the same Luminex panel in both CAP scan fluid and then also plasma samples. And our preliminary results show that many markers tend to be higher in plasma, which you can see here on the, you can see on the right, while a smaller subset seem enriched in CAP scan device, and this suggesting that localized mucosal activity may not always be fully reflected systematically. We then wanted to test whether CAP scan measure can distinguish between celiac disease from healthy participants at baseline. So we compared CAP scan inflammatory profile at baseline between the newly diagnosed celiac patients and the healthy control. We observed a trend toward higher level in celiac for a cluster of analytes. So that, So that's on the right here. For a cluster of analytes, that are several of them are showing at least like twofold or greater increase, mostly in like pro-inflammatory markers, and all that is kind of to suggest that we can directly measure inflammatory markers at the mucosal site and could help us distinguish between celiac from healthy states. Finally, I wanted to see how these markers will do longitudinal as patients start their treatment. So in this small pilot study, what we did is we selected 7 participants who had initiated gluten-free diet. And then we can see direction and change in some of the inflammatory markers. For example, inflammatory factors such as granzyme A tend to decline, while other tissue repair-associated markers like MAP9 will show transient rise around 3 months and then will decline. Also supporting the idea that we can use these methods to monitor mucosal inflammation over time. So in short, this pilot study have showed us that we can use a non-invasive capsule to sample the small intestine, and this can be done safely and non-invasively in patients with celiac, and measure inflammatory markers directly from the site of disease states at the small intestine. This could allow us to potentially separate between patients who have the disease from patients who do not have the disease, and more importantly, could also serve as a potential marker to monitor disease activity over time. This really pilot study is just setting up the groundwork for a larger study that would be powered to develop and validate non-invasive biomarker for disease monitoring and therapeutic response, and also will allow us to go into deeper mechanistic insights while integrating these into with other multi-omic analysis measures. Thank you. I would mostly like to thank my mentors, David Drellman and Trishan Khosla, as well as our clinical partners and especially funding from the MCHRI Fellowship Award that have allowed me to do this work, and to all the participants. And with that, I'll take any questions.
It's a really cool story. I was wondering, like, the samples that you collect, are they, how are they stored? I mean, I noticed that a couple of the markers that you found are proteases. We work on proteases. And I'm wondering if any of them would retain activity, because there are a lot of sensitive measures for proteolytic activity.
Yeah, that's a great question that we have thought a lot about. So typically with the patients, we tend to tell them to, once they collect these CAP scans, to just like put them in the freezer, and then as soon as possible, we'll send them some like ice, some frozen nitrogen, and then they could like send it back to us. So typically the only thing we have done is like store it at -80, but we have done studies where we have, to be able to answer that specific questions, we took some aspirates from the duodenum, and then we're trying to see how these CAP scans change over time.
Yeah.
To trying to see whether what we're really seeing could be affected by the protease that are present in the medium. It definitely shows that some of them will decrease initially, but then at some point they will kind of stabilize.
Yeah, I mean, because we have, for example, well, one of my former postdocs just put out a paper on a really sensitive granzyme B probe, which is covalent. So you could actually put that into the sample and then use that as a readout of whether granzyme B is there, which is a marker of activated T cells. So it's
Oh, wow.
something to think about.
Yeah, that sounds great. Yeah, thanks for the suggestion.
Thank you. Thank you so much.
Yeah, of course, thank you.
Terrific. Excuse me. Our next speaker is Rebecca Gardner, I believe. Are you here? Oh, great. Please come up to the podium. A graduate student who will be talking about hyperemesis gravidarum and risk for adverse pregnancy outcomes.
Thank you. Thank you so much for the opportunity. So I'm a fourth-year PhD student in the epidemiology department, and today I'll be talking about the association between hyperemesis gravidarum and adverse pregnancy outcomes. So nausea and vomiting occur in 70 to 80% of pregnancies, but the severe form of nausea and vomiting, hyperemesis gravidarum, occurs in 2% of pregnancies. And despite being a rare condition, it's the second most common reason for hospitalization in pregnancy. And HD is characterized by significant weight loss. And in one study of 800 women with HD, a quarter of them had even extreme weight loss, which is greater than 15% of pre-pregnancy weight, which just underscores the metabolic famine that these patients endure. HD patients also have compromised nutrient intake. They consume less than half the recommended amount for most nutrients, including critical micronutrients for development, such as folate. HD can also have a severe negative impact on the quality of life for the mother, and both during and after pregnancy. For example, in a Danish registry study, they found that HD was one of the most important predictors for postpartum depression, even more than important childbirth outcomes like postpartum hemorrhage and emergency C-section. And so HD is characterized by this poor nutrition that occurs during a critical window of fetal and placental development. And so we think that this undernutrition can lead to, well, there's evidence showing that it can lead to abnormal placental function and insufficient blood supply to the placenta. And then this is what could potentially increase the risk for adverse pregnancy outcomes. So a meta-analysis published in 2023 did indeed find this link between HG and APOs. However, the studies included had several shortcomings. For example, the results had quite large accompanying confidence intervals, and this was in part driven by several of the studies being underpowered. For example, 6 of the 23 studies included less than 100 individuals with HG in their studies. Notably, most of the population-based studies in this meta-analysis came from European countries, particularly Scandinavian countries. There was only one population-based study from the United States. And this study was published 20 years ago. It used data from 1999. And because it was more descriptive in nature, it didn't account for important confounding between HG and APOs. So our objective here was, because we know that there's underlying population differences between countries, especially between European countries and our own, and also differences in clinical health systems and practices, we wanted to perform a population-based study in the United States and to determine whether HG increases the risk of adverse pregnancy outcomes, and also to adjust for important confounding between HG and adverse pregnancy outcomes. So we used California vital records linked with hospitalization data, also known as MCHRI, which I'm sure many of you are familiar with. And our cohort included about 2.5 million singleton live births. We defined HG using primary diagnosis codes. And we used Poisson regression models to fit or to calculate the relative risk for each adverse pregnancy outcome, adjusted for important confounders that were present in the literature. We also further classified HG by whether the first hospital admission was in the first trimester or the second trimester. And this was based on our previous paper that did this in Sweden. So you can see here we identified nearly 54,000 pregnancies that were complicated by HG, quite a large number. And this comprised about 2.2% of our cohort. And you can see here that we have quite a diverse group of individuals with respect to race, ethnicity, and also insurance at delivery. Just a few to point out. You can see that there's a much larger proportion of non-Hispanic Black women in the HG group, a lower proportion of Asian women, and a lower proportion of Hispanic women compared to the non-HG group. And here's our table of outcomes. So starting with the hypertensive disorders of pregnancy, the first few rows, they were all higher in the HG group. And you can see any preeclampsia was 4% in the HG group versus 3.3% in the non-HG group, which corresponded to a 17% increased risk for preeclampsia in the HG group. We saw a 25% increased risk for preterm birth, and this was driven mostly by a higher rate of spontaneous preterm birth and also a slightly higher rate of medically indicated preterm births. We saw a 19% increased risk for small for gestational age, and we also saw a higher rate of female infants in the HG group. So the male to female sex ratio in the HG group was 0.92 versus 1.05 in the non-HG group. And universally, this is about the male to female sex ratio is about 1.04. So we saw it was quite lower for the female and for the HG group. And lastly, we saw a 37% increased risk for anemia diagnosed at delivery. So this is looking at the outcomes by trimester first HG hospitalization. And in general, we saw that for several of these outcomes, there was an increased risk for HG that was first documented in the second trimester. For others, we have quite large or overlapping confidence intervals, and for some there was a slightly decreased risk, maybe like anemia. But you can see for any preeclampsia that the risk was elevated for HG that was first documented in the second trimester. So in conclusion, we found that HG hospitalization was associated with an increased risk for hypertensive disorders of pregnancy and other adverse pregnancy outcomes. And we did see for some of these effect sizes that were greater for the HG that was first documented in the second trimester. And our study adds to a growing body of literature that is at odds with the existing clinical guidelines, which emphasize the need to reassure HG patients that Hyperemesis gravidarum portends well for pregnancy outcome. And I'd like to thank my advisors, mentors, and also co-authors on this project. Thank you. And
While people are formulating their thoughts, I have a question, and I'm actually really curious about what do we know about the reasons behind the population patterning of HG to begin with, particularly by race ethnicity. I found that really quite
yeah, so race ethnicity, so because we don't have very much data on population studies in the United States, this is probably going to be one of the first that we have. And actually in European countries, we've seen that Asian races are actually considered a risk factor for HG, so we see higher rates of HG in those patients. But here we see the reverse.
It's really
So
interesting. So more work to do.
Yes.
Hi, great work. I can ask a quick question. So, am I right that you used antepartum hospitalizations or emergency department visits? Did you consider using the delivery hospitalization data? Because I'm just thinking, so these would be the most severe cases, presumably, of people with HG, that they were hospitalized while they were pregnant or went to the emergency room. Versus like at the delivery record, everyone has a delivery record and they would have within their whole long list of diagnoses potentially HG documented.
Oh, I see. So you're wondering if we use delivery hospitalization records to say whether or not someone had HG?
Yeah, because I don't think you necessarily know those no HG people didn't have HG. They just didn't have an antepartum hospitalization or ED visit for it. And maybe you'd get a better, broader capture if you added in the delivery hospitalizations.
Yeah, we can definitely look into that because yeah, we will only use the prenatal hospitalization and the emergency department encounters.
Just an idea to
Yeah.
think about.
Yeah, thank you for that recommendation.
Well, thank you so much.
Thank you.
Thank you so much. Very nice. Well, our next presenter is Dr. Alireza Raissadati, who is an early career faculty member and instructor with us, who will be talking about plasma cell-free DNA profiles of tissue damage. Thank you so much.
Appreciate it. Let me just get settled. This works. Perfect. Thanks for that introduction, and thanks to the MCHRI for the opportunity to come and present some of the exciting work we've been doing in cell-free mRNA liquid biopsy field. I've been doing this all under mentorship of the fantastic Dr. Sean Wu. I have no conflicts. Let's start by talking about acute rejection. It's a major cause of post-heart transplant morbidity and mortality. It's characterized by an antigen-specific adaptive immune response against the transplant, triggering a vicious cycle of cytokine and chemokine production, attracting more immune cells to the graft in a process we term acute rejection. There's two subtypes. There's acute cellular rejection that's characterized by this patchy, profound lymphocytic infiltrate and myocytic necrosis that you can see on this H&E slide here. And then there's antibody-mediated rejection that's an antibody specific to the graft produced by plasma cells, causing complement activation and deposition on the endothelial cells, which we can actually image with immunohistochemistry, immunofluorescence, which we usually do as a diagnostic practice. The issue with acute rejection is that the lifetime incidence is around 40% for all of our transplant patients, with around 20% of adults and kids getting rejection within their first post-transplant years, accounting for about a third of all deaths within the first 5 years after transplant. The major unmet need in this field is the suboptimal current gold standard diagnostic test we have for acute rejection, consisting of endomyocardial biopsies. And we perform this with a catheter through either the groin or neck vessels, grabbing a piece of the right ventricle and observing it under the microscope, with the slides you saw in the previous slide. The issue is that it gives you lots of false negatives, especially in the early phases of rejection, and it carries risk of complications, including hematomas, tricuspid valve damage, and cardiac perforation, particularly in the pediatric population. It's got diminishing accuracy as fibrosis develops at the repeat sites of biopsy, and it also reduces quality of life after transplantation, since all of these patients need to undergo this invasive procedure. We propose a solution in cell-free messenger RNA-based liquid biopsies to replace this tool. Cell-free mRNA are essentially protein-coding genes floating in our plasma, originating from all cell types of the body. It is thus a very rich source of non-invasive data we can actually trace back to the cellular sources using appropriate computational algorithms, and it's already been proven in a variety of disease forms. Here I highlight these biologically elusive pathologies like preeclampsia and malignancy, and it's got an edge over existing biomarkers, the majority of which have ambiguous origins and functions. And I'll highlight donor-derived cell-free DNA here, which is proving to be an excellent non-invasive tool we're using increasingly in clinic for acute rejection, but it provides only binary information that doesn't really describe the nature of the graft insults. We, in our hands, validated our platform in immune checkpoint inhibitor-induced myocarditis, comparing these patients to their corresponding controls that were on ICIs for cancer, but did not have cardiac complications. And our platform successfully captured the subtype of CD8 positive T cells that was driving the inflammation, and also the downstream cardiomyocytes and conduction system cells that were dying in the process. And we used this disease-specific signature to create a cell-free mRNA classifier that outperformed an unsupervised gene panel we got from machine learning algorithms in dissecting and distinguishing these ICI myocarditis patients. So we're now going to deploy this to acute rejection, but since this is a very evolving process with lots of clinical confounders, we decided to take this into a mouse model first, specifically using the heterotopic abdominal heart transplantation model in mice, in which we connect the donor heart to the abdominal vessels of the recipient, giving us a fully vascularized beating model with complete variable control and reliable ground truth, which is super important in this setting. We know from over 3 decades of experience using this model in countless studies that by post-op day 10, if you have a fully MAC mismatched model, all transplants are completely obliterated from rejection. And the added benefit is that I used this extensively during my PhD, and I'm very comfortable using it, and we're doing it now in collaboration with the Shudo lab. The objectives of the study were to establish the plasma cell-free mRNA profile of acute rejection in mice, and then to assess the kinetics of the profile as AR was developing. To this end, we had 2 control groups. One was just baseline native C57 mice, for which we obtained blood at the baseline. Then we did syngeneic transplant between C57 mice. And then the condition of interest was fully MAC mismatched allogeneic transplants between BALB/C to C57 mice, both transplant models having 2 hours of cold ischemia time to mimic the clinical scenario. We obtained blood at post-op days 1, 4, 8, and 10 in a new assay we developed to actually get cell-free mRNA from low volumes of plasma from mice. The model works. 100% of the allogeneic mice or transplants reject by day 10. We can salvage that by introducing some immunosuppression, and all the syngeneic transplants survive well past day 10. And this is corroborated in the histology, where you can see complete obliteration of the allogeneic transplant, whereas the syngeneic perfectly preserves the tissue architecture. And then we started off by just obtaining a macro-level overview of the cell-free mRNA landscape by comparing syngeneic and allogeneic transplants to native at post-op day 1 and 8. And you can see in the upper panel how the number of dysregulated genes are downtrending in the syngeneic model as we get further away from the surgery, indicating that this is a resolving situation, whereas in the allogeneic model, you see a significant uptick in the number of dysregulated genes, indicating that we're actually capturing some form of evolving acute rejection pathology. And then we wanted to suss out an AR-specific signal, so we compared allogeneic to syngeneic mice at post-op day 8. We found significant numbers of dysregulated genes. We put the upregulated ones into a machine learning algorithm that put out 2 clusters of gene based on gene expression profiles, all in a condition-agnostic manner. And when we looked at the diseases enriched, there was lots of inflammatory and cardiac diseases. We took the 175 DEGs in this cluster and performed granular pathway analysis and found loads of inflammatory and cardiac-related pathways enriched. And we took the top 50 genes from this cluster that were overexpressed in the allo group, and their expression level uptrended with worsening AR in the allogeneic group, but not syngeneic. And when we traced these back to the cellular sources, we saw an increased signal of not only cardiomyocytes in the allogeneic group, but also of immune cells. So from this, we can conclude that the AR-specific genes do reflect this evolving AR pathology. The platform gives us robust cell-free mRNA yields from serial mouse blood samples, and we can conclude that the profile we're seeing so far is capturing the evolving acute rejection in mice with both temporal and biological correlation. The limitations were that this was a preliminary study, so we're working on getting more samples to get more robust statistics. We mitigated the background noise by using both unsupervised and supervised gene expression analyses methods, and then we mitigated cell type gene overlaps by using stringent expression thresholds. The near or short-term future directions is that we're completing the mouse study right now, and then we're gonna collaborate with my co-mentors, Drs. Kush and Valentine, using their heart transplant biobank for taking this to the clinic and actually analyzing patient samples with the near-term goal of distinguishing between AMR and ACR. And long-term, and this is what I'm super excited about, is that we now have a validated cross-species disease-agnostic liquid biopsy platform to inform us not only of rejection but all post-transplant complications and beyond in a holistic long-term surveillance platform that we can employ across all of our heart transplant patients. And I want to thank our lab and all of our collaborators and our funding sources. Thanks so much.
That was awesome. Great study. How much depth can you get in the RNA sequencing? Can you get like T cell subtypes, MHC, to understand like which epitopes are being attacked? Can you get that much depth?
I wish we could get the epitopes. We're working on that piece.
Yeah.
There's some computational algorithms that can take bulk RNA sequencing or maybe stitch some together, which I'm working on. But in terms of cell types, yeah, we can get to subtypes of T cells.
Fantastic. Thank you so
Thanks.
much. I'd like to invite our next speaker up, Dr. excuse me, Aditi Sharma, who's going to come and speak to us. Switching gears a little bit from the more molecular to the more macro, thinking about how do we encourage children to drink more water and healthy beverages.
Good afternoon, everyone. Thank you for this opportunity. So today I'll be presenting about the qualitative findings of our study in a childcare-based program to promote water intake called Healthy Drinks, Healthy Futures. To give you a little bit of a background, so sugar-sweetened beverages are the top source of added sugar in children's diet and also are a major contributor to obesity-related conditions and dental caries. And early childhood settings are key for shaping beverage habits of millions of US children. And so to address this problem, we developed a study called the Healthy Drinks, Healthy Futures, which is a clustered randomized controlled trial that examines the impact of childcare-based water promotion interventions on children's beverage intake at childcare and at home. And so 14 childcare centers serving low-income families in Santa Clara County participated in the study. And as childcare providers are key implementers, understanding their perspectives on the feasibility and sustainability of our study is critical. Just to give you an overview of the components of the Healthy Drinks, Healthy Future study, first we did lead testing in the centers to make sure that the water is drinkable and safe. We provided reusable water bottles, pitchers, cups to increase water access at home and at childcare centers. We provided training to the providers and also helped them set healthy beverage goals. And our educational components included 7 lessons on water, the Potter the Otter book, Drink More Water song, and then we had handouts about sugar in various drinks. We used a community-based participatory research approach that was guided by a community advisory board. This was a qualitative sub-study of the Healthy Drinks, Healthy Futures study. We did 6 Zoom-based focus groups with childcare providers, a total of 16 childcare providers from 5 childcare sites in the first 2 cohorts of the study. The interview guide was guided by the CAB and covered the intervention, the water and SSB access, beverage habits and barriers, and we finally did a thematic analysis following the consolidated criteria for reporting qualitative research, or CORE-Q. So here are the results, and I've put direct quotes from the providers, which were representative of the childcare providers from the focus group for you to read. The first one is on educational components. So the childcare providers reported that there was an increased water intake among children after the study. The interactive lessons were very engaging for kids, and visuals like posters and images sparked curiosity, and kids became advocates and started repeating the messages to their friends. There was also a homeschool synergy because we sent bilingual handouts and educational materials back home as well. However, there were some developmental mismatch for toddlers because some of the concepts were too abstract for the younger kids. The Potter the Otter book, they said, were too long or wordy for some younger kids, and it was a little bit flimsy for the kids to play with. For reusable water bottles, I'll start with what didn't work. We had provided water bottles with pictures of the children, which they loved, but it was very labor intensive for the staff to clean because it had to be hand washed. And then the sip top was prone to debris buildup, so long-term upkeep was difficult without additional support. However, we found that all centers reported ongoing use with the new and returning children, and they had shifted the bottle care responsibilities from the center to the families, which reduced staff burden while maintaining hygiene and parent engagement. At the center level, federal, state, and site-level policies reinforced the Healthy Drinks, Healthy Futures goals, and some centers started to move away from juice even during special occasions, and they credited that to our study. The teachers said that they were now drinking water visibly around their children, and they were only drinking coffee and soda in the break rooms, and they stored it there as well. They also started providing routine prompts to encourage water intake, especially when they came back from outdoor playtime. They would be like, use the bathroom, wash hands, and then drink water. Despite testing for lead and providing safety assurances, there was still widespread mistrust for tap water quality due to taste and appearance and smell, so all aesthetic reasons. And so tap water was restricted to cleaning, and they didn't use it for drinking or cooking. And they used filtered or bottled water instead. After this completion of the Healthy Drinks, Healthy Futures study, the childcare provider said that the hydration breaks, teacher modeling, and activities were embedded into their daily schedules, and educational materials were reused and adapted. And the Potter the Otter book and the water-themed lessons were used with even the new student cohorts. And the provider said that they noticed a long-lasting classroom culture shift. For the vision for the future, the childcare providers mentioned that they would like this program to be expanded to more age groups, both younger and all the way up to elementary, to help develop habits. And then they also wanted us to prepare children for real-world choices because, when they went out to parties or restaurants, they would still have those temptations to drink sugary beverages. And then they wanted us to engage families more deeply, so create communication channels with the families to talk to them directly. They would also like us to broaden nutrition education scope, just from water to a full balanced meal. So from the interviews with the childcare providers, our key takeaways were that the Healthy Drinks, Healthy Futures study promoted water intake through structured, engaging, and relevant strategies. Sustainability was improved through shared responsibilities, like the example I provided about the bottles. And then finally, developmental fit and logistical ease are essential for long-term success. I want to give an acknowledgement to our PI, Anisha Patel, and my study team in the back, all our study partners, our community advisory board who have throughout provided feedback for the study, and our funders, the MCHRI SURF grant. Thank you so much, and I'm happy to take any questions.
So much for that presentation. Are there any questions from the audience? I have one. I'm curious, did you ask families about their perceptions of this intervention and about what their kids were coming home and sort of talking about what their family's nutritional choices may or may not be? I'm curious.
Yeah, thank you for that question. Actually, part of that SURF seed grant was to interview parents and childcare providers. So we interviewed 36 families from like Spanish-speaking, Vietnamese-speaking, English-speaking families. And the results are pretty much similar, but there we also noticed that there was an improvement in self-efficacy among parents as well. Like they were feeling more empowered to help their children drink more water and less sugary sweetened beverages.
One quick one and then we'll have
Okay, sure. Hi, Aditi. Thank you. I was just wondering if it's coming into the conversation, microplastics with the different water storage plastics, water bottles, or buying bottled water. I know it's a complex issue, but we're hearing more and more about microplastics. Thank you.
Yeah, thank you. We've been talking about microplastics a lot within our team. The issue of microplastics didn't come up a lot when we were talking to childcare providers and parents, but the community advisory board and our advisory board in general have been concerned about microplastics. And so for our next study, for the TAP Trust study, we've been developing a handout with all the information about microplastics in water bottles. Yeah, thank you.
Great. Thank you so much.
Thank you.
Okay. Our final speaker for this session will be Dr. Lu Yang, who is going to be speaking to us about forecasting out of safe range vital signs in the NICU. Thank you so much, Dr.
Thank you for the very kind introduction. Also, I thank the committee for inviting me to share my work. Today, I'm presenting my work in the interdisciplinary area of the neonatology and artificial intelligence. I'm a postdoc working with Professor Nima Agipur. This morning, as he mentioned in his talk, our rich experience in this field have shown that the AI has great potential in improving neonatal healthcare. My current work focuses on the NICU patient monitoring. One of the most important and high-volume dataset comes from the bedside monitoring machines. The vital signs on these machines are always reviewed by clinicians for decision-making. In this work, we currently consider the EHR data and the vital signs. Here is an example of the vital sign. Well, the current monitor alert when any vital sign goes too high or too low. It takes time for clinician to respond. By the time any intervention is made, the vital sign has been always out of the range for a while. Therefore, we asked, can we develop a novel bedside monitoring system which can forecast the risk of vital sign moving out of the range? If yes, this could potentially provide a longer time window for clinician to check the patient, turning the previous reactive care to the proactive care. Our current cohort contains more than 2,000 NICU newborns. We first computed the time ratio of the vital sign being above or below the safe range, and we found that the distribution of these time ratios differ between the case and control patients across many neonatal morbidities. To make this clear, let's take the bronchopulmonary dysplasia and oxygen saturation pair as an example. In this plot, the x-axis represents the averaged time ratio of the oxygen saturation below 90% among the control patients, while the y-axis represents the averaged time ratio of the oxygen saturation below the range among the BPD patients. So we can see the BPD patients have overall higher time ratio of the oxygen saturation being below the range. Now looking at a wider area of the vital sign and the conditions, we found that the time ratios of the vital sign remaining out of the range is associated with many neonatal morbidities. That's why we developed this multitask deep learning model to predict the upcoming clinical vital sign abnormalities. We first embedded the historical EHR data using a foundation model called Motor. Then we extracted the representative features from the most recent 10 minutes vital signs in these 5 different categories, and then we encoded them as well. Finally, we created a multi-head neural network to simultaneously predict these 4 clinical use cases. For designing an experiment, we randomly select 100 prediction time per patient in each day during the first 3 days in NICU. Again, here the question is, at any prediction time, how well we can predict the risk of a series of abnormal vital sign event in a future window by observing all of the historical EHR data and the most recent 10 minutes vital sign. Let's walk through the 4 use cases. The first one is a desaturation. From one of the previous slides, we see the oxygen saturation below in the range is associated with many neonatal morbidities. So accurately predicting the desaturation event is very important, as it can help the clinician to decide whether the oxygen support is needed and to determine appropriate level of the oxygen support. We use both the RC curve and the PR curve to evaluate the prediction performance. You may be more familiar to the RC curve. Our model can reach to a relatively high true positive rate at a relatively low false alarm rate. And we also use the evaluate the AU-PRC, which is indicated by the area under the blue line on the right-hand side. We can see the model's AU-PRC score significantly outperforms the event prevalence, which is indicated by the area under the red dot line. And this tells us our model can accurately predict the desaturation event in the future 5 minutes window. And we also tested our model for the severe desaturation. We see this result is slightly worse than that for the desaturation, but it's still pretty good if we consider this is a very rare event. And the other 2 use cases are bradycardia, heart rate less than 100 BPM, and the bradypnea, respiratory rate is less than 30 breaths per minute. And here are the results, and which are pretty good, especially for predicting the bradycardia. Finally, let's take a look at an example. While we also predicted the bradycardia and the bradypnea with a pretty good score, now let's focus on the last one, the desaturation. So we see the probability score of the desaturation event is 0.83, while the score for the severe desaturation is 0.02. This is pretty accurate because in the future 5 minutes, you see the oxygen saturation occasionally drop below 90%, but never cross the 80%. So what is the next? We have tested our model using the first 4 clinical use cases, and we reached to a promising result. And we aim to make our model more generalizable and to make it to be useful in a wider range of the clinical scenarios. So we have listed a series more use cases to explore. However, I'm not a physician, and we're not also physician. So we don't have clinical experience. We very welcome your any valuable ideas and suggestions to this work. I finally sincerely thank all of the advice and support from all of my mentors, collaborators, lab members, colleagues, and friends. I also thank MCHRI for funding my research. Thanks.
I very much appreciated your last slide, and you certainly are working with some clinicians and some of my colleagues who I'm sure have lots of insights. I think for me, this is a really, really amazing work in terms of forecasting. But then, of course, the next question is, can we do anything to intervene? And I think those are some of the really important clinical questions, right?
That's where we start this work. Like first, we think about even like we know that we also predict the neonatal outcomes, but sometimes even we know the probability of a baby, having a certain disease, but we don't have a lot action we can do. Exactly. So that's why we predict the vital sign moving out of the range. Then, for example, the oxygen saturation. Then the clinicians maybe can intubate. Have more options to intubate.
Great. Yeah. Very good.
Yeah.
Well, I'm so sorry. We do have we are at time. Maybe we can find each other afterwards.
Yeah, we can talk later. Yeah.
Very good. Thank you so much. I'd like to thank all of the presenters. It really is inspiring to hear all of your work. I think now we have a bit of a break, and then please come back for our last session, which is about devices and therapeutics in maternal and child health. Thank you.